Thank you for joining my presentation on case studies in monitoring the ICU patient. My name is Terrence Shenfield, and I've been an educator for the last 30 years. This course is approved for 1 AARC CEU. The objectives of today's presentation is I'm going to go over certain case studies on EKGs. I'm going to get a little bit into hemodynamics, talk a little bit about opioid overdosing. I'm going to talk about ethical challenges in healthcare. And finally, I'm going to finish up with a topic on sedation. I hope you enjoy this presentation because it's going to go into a lot of different case studies speaking about all of these particular topics. We're going to start today's presentation with EKGs. I'm going to go over a couple of different case studies and show you the strip and anticipate that you'll recognize what kind of rhythm it is and what would you do about it. Our first case study is about a 76-year-old man with a history of smoking was referred to our hospital with worsening dyspnea. He's been taking medications for chronic obstructive pulmonary disease for 3 months, including theophylline, which was around a dosing of 200 milligrams twice a day, a long-acting muscarinic antagonist, and a long-acting beta-agonist inhaler. His blood pressure upon arrival was 121/63. His heart rate was 192. His respiratory rate was 30 breaths per minute, and his temperature was 36.3. They decided to do an EKG, and when they did the EKG, I want you to tell me what the rhythm is on the next strip. So they did the EKG on the patient, and this is the rhythm that they came up with. So I have a couple of questions for you. Number one, what is the heart rate of this patient? How can you estimate the heart rate of this patient? There's a couple of ways. Number one, each of these right here, this is the QRS complex, right? QRS complex, QRS complex, QRS complex. And one of the simplest ways to measure the heart rate is to count the number of boxes and divide that into 300. Say, for example, each of these boxes, this box right here, from here to here to here to here. So what you do is how many QRS complexes occurred? There's one box, two boxes. So 2 boxes occurred, and so what you would do is you would take 300 divided by 2, and that comes out with an approximate rate of about 150 beats per minute. The QRS complexes are regular. The heart rate is about 150 beats per minute. What kind of rhythm is this? Do you recognize this rhythm? If you don't, this rhythm is called supraventricular tachycardia. This is called an SVT rhythm. So the question is, now that this is an SVT rhythm, what do? What kind of treatment modalities can you do to treat an SVT patient who's in this kind of rhythm? Remember, the heart's beating so fast that the delivery of blood to the body is decreased because there's not enough time for the ventricles to fill up with blood. So this can have some kind of impact on you. So I want you to tell me, how would you monitor the patient? What would you do about it? So now that you know the EKG strips reads for SVT, how would you treat it? There are a number of treatments that you can do to treat SVT. The first question you need to ask is the patient showing any signs of decompensation? In other words, is there some immediate treatment needed, or is the patient in SVTs and basically asymptomatic? So there's a few things you could do. And one of the first things you could do is carotid sinus massage. Basically what that is that the carotid artery that's on the neck is massage gently for about 5 seconds. And what happens is this actually will decrease the likelihood of getting an SVT and reverse it. There's a problem with it, though. If a patient has any kind of history of stroke, this could be very dangerous because it could release any kind of clots from the carotid massage. So you got to be careful with that. The second thing you could do is a vagal maneuver. A vagal maneuver is, I'm sure you're quite used to this. Basically, you hold your breath and you bear down. A lot of times the vagal maneuver will actually reverse the SVT. Then finally we get into cardioversion. Cardioversion is if you are symptomatic and you have SVTs, cardioversion is the sign of the choice. So what you need to do is be in a hospital setting. They will give you some form of sedation and they'll cardiovert you, and this actually is basically like being shocked. You know, they kind of got a couple of leads they put on your chest and they shock you and to get the rhythm back into normal. Sometimes you could use medications. It all depends. Like some people with persistent SVTs can be treated with different types of medications. And those medications are amiodarone, calcium channel blockers, beta blockers, and all of these drug choices are good for people with recurrent SVTs. And finally, if you have SVTs that doesn't respond to medications and doesn't respond to any kind of cardioversion and keeps on coming back, you can use ablation. What ablation is electrodes that actually emit a high frequency radio frequency energy, and they ablate small spots of heart tissue that creates a blockage to the pathway for SVTs. So these are the choices. You got your carotid sinus massage, your vagal maneuvers, cardioversion, medications, and as well as if everything doesn't work, we could do ablation. This is our second case study. A 67-year-old man presents to the emergency department with palpitations and dyspnea, which began approximately 4 hours ago. He has a history of hypertension, diabetes, GERD, and his current medications are lisinopril, metformin, and omeprazole. He has no history of congestive heart failure, stroke, or any kind of transient ischemic attack. He appears to be in mild respiratory distress. His blood pressure is 88/60. His heart rate is 140. His respiratory rate is 24, and his temperature is normal. They do his oxygen sats, and they are at 90% on 40% via face mask. They did a cardiac exam, which showed tachycardia with irregular tachycardic rhythm. There are crackles in his lower lung fields, and they actually did an EKG on him. The next slide will show you the EKG, and your job is to tell me what kind of rhythm that is. Now that they conducted a EKG on the patient, this is the rhythm you see. Basically, you got a narrow QRS. The rate is regular. It seems like the atrial rate is around 300 beats per minute. And I want you to tell me exactly what is this. And you should be able to recognize this rhythm because it's a common ACLS rhythm. I could tell you something, that it's a re-entry problem with the right atrium. That is the cause about this. The right atrium gets a re-entry electrical conduction to it, resulting in this pattern. So what is this pattern? And you should recognize that this is atrial flutter. Now that we identified that the patient's rhythm is atrial flutter, and we also agree that the patient is in hemodynamically instability, what would you do? Now, why would I say this patient is hemodynamically unstable? What made me think that? And what made me think that is that the patient presented with hypotension and pulmonary edema. As a result of presenting with hypotension and pulmonary edema, he needs to go under cardioversion without the anticoagulation therapy. So in other words, you got to shock him, you got to convert that heart rate to a normal rhythm. So that is the first thing you do. When you do that, his rhythm will convert to a normal sinus rhythm, and he should become a little bit more stable, and his vital signs will start to return to normal, and his symptoms will dissipate. The problem with that is there's a possibility of clots, thromboembolism. So you really have to identify that, and you really need to develop some kind of anticoagulation therapy. The reason you do that is that even though he has a sinus rhythm that is normal after cardioversion, he is still at risk for thromboembolism. So for the next 4 weeks, you need to develop some kind of anticoagulation therapy that should be continued for 4 weeks, and then you reassess the patient. This is very important to do. If after 4 weeks of the anticoagulation therapy, everything is normal and his rhythm doesn't go back to atrial flutter, you could discontinue this therapy. But if his rhythm goes back to atrial flutter, then you really might have to consider long-term use of a thromboembolic medication. Another control here that we need to look at is rate control. And most rate control, heart rate control, is done with beta blockers. So you really got to look at the whole picture of this patient with atrial flutter, and you really need to consider thromboembolism, and you have to also consider beta blockers for rate control. Case number 3. The patient is a 60-year-old female presenting to the emergency room with acute onset of shortness of breath. The symptoms began approximately 2 days ago and had progressively worsened with no associated aggravating or relieving factors noted. She had a similar symptoms approximately 1 year ago with an acute chronic obstructive pulmonary disease, exasperation requiring hospitalization. She does use a BiPAP at home at night when she's sleeping, and she also requested to use this in the emergency room because of shortness of breath and also wanting to sleep. She denies any kind of fever, any kind of chills, any kind of cough, any kind of wheezing, any kind of increased sputum production. She has no chest pain, no palpitations, no abdominal pains, no distension, no nausea, no vomiting, no diarrhea. So what's going on with her? So they did an EKG on her. So they do an EKG on the patient, and this is the strip they develop. I have a couple of questions for you. Number one, what is the heart rate of this patient? Remember before, you have the QRS, you have the QRS, you have the QRS, and in between the QRS you have these big blocks, number 1, number 2, number 3, and number 4. So one of the easiest ways to determine the heart rate is to take the number 300 and divide it by the number of big boxes. So we have 4 boxes. 300 divided by 4 is 75. So the heart rate here is around 75. Is 75 normal? I would think so. The second question is, you look at the QRS. Is the QRS narrow or wide? The QRS is narrow. Is that normal? Yes, it is. So you have a normal QRS complex. Third question, let's look at the P wave. The P wave always precedes the QRS complex. So here's the P wave, here's the P wave, here's the P wave, and here's the P wave. If you notice, the P wave is almost in the exact location, less than 0.2 milliseconds before the QRS complex. Is that normal? And the answer is yes, that's normal. And finally, we get to the T wave. And so the T wave occurs after the QRS complex. And this is a T wave, this is a T wave, this is a T wave. And if you look at the T wave, it looks relatively normal too. So with all that being said and done, what is going on with this patient? What is going on with this rhythm? And the answer is absolutely nothing. There is nothing wrong with this patient's heart. This rhythm is a perfect EKG of a normal sinus rhythm. So now that we know we have a normal sinus rhythm, what do? And the answer is we do nothing. We have to do nothing for the heart of this patient. The problem with this patient is not the heart. The problem with the patient is that she's having a COPD exacerbation, and she got to be treated for that, not a heart. So this was a little trick for you guys. I try to trip you up. Here we are with case study number 4. An 87-year-old woman reports feeling weak and short of breath for 2 hours while walking short distances. She feels exhausted moving from the car to the ED stretcher. On a physical exam, she is pale and sweaty. Her heart rate is 35. Her blood pressure is 90/60. Her respiratory rate is 18 breaths per minute. She has no chest pain or ischemic symptoms prior to the onset of her weakness and shortness of breath. So from what we can see, her heart rate being at 35 makes her bradycardic, and her blood pressure 90/60, that's hypotensive. So she's definitely got some issues going on. So they decide to do an EKG on her. Good move. So let me show you the EKG. So this is the EKG they have on her. And I wanted to go over a few things with you. Number one, what kind of EKG is this? Let's analyze it. The QRS complex, are they narrow? Yes, they are. So let's go to step 2. Is her heart rate regular? Are the QRS complexes regular? No, they are not. There's 1, 2, there's nothing here, there's 1, 2. Let's look at some other stuff. Let's look at the P wave. So here's our P wave, here's our P wave, here's our P wave, here's our P wave, here's our P wave. The P wave is right before the QRS complex, less than 0.2 milliseconds, and it's very stably normal. The problem is that we have a PQRST, PQRST, we have P, no QRS, no T wave, and then we're back to normal. So when you look at this rhythm, what do you have here? What kind of rhythm is this? You tell me. From the EKG, we could see that she has a second-degree heart block type 2. And what differentiates a type 2 heart block is the fact that she has a missed QRS complex. Now, if she was asymptomatic, how would you go about treating her? How would you treat someone with this particular rhythm who's asymptomatic? The answer is you really don't have to do anything at this point with her until she arrives at the hospital. There's nothing you really need to do with her. But the fact that she was symptomatic because she was hypotensive, she was pale and sweaty, and she was very weak, and she was hypotensive, begs the question that something has to be done immediately. So what would you do? And the answer would be you need to pace her. Basically, she has a second-degree heart block type 2, also known as a Mobitz type 2. And basically, what you really need to do as soon as possible is pace her. So pacing is the required treatment for her immediately. Basically, a heart block, a second-degree heart block, talks about some kind of structural damage with the AV conduction system. And sometimes this heart block can completely deteriorate to a complete heart block, which, she could possibly die. So this is a very severe case. Something has got to be done immediately, especially the fact that she is symptomatic. These patients typically require pacing until a pacemaker is placed with them, and this is the normal treatment process for these. This is our final case study for EKGs. There's a 57-year-old male truck driver who presented to his local emergency department with a 20-minute episode of diaphoresis and chest pain. The chest pain was central. It radiated to the left arm and crushing in nature. The pain settled promptly following a 300 milligram aspirin given orally and 800 mics of GTN given sublingually, which was administered by the paramedics. He has a smoking history of 20 cigarettes daily, a total of 38 pack years, but was not aware of any other kind of cardiovascular risk factors. When they examined him, he appeared comfortable and was able to complete sentences fully. There were no heart murmurs present on cardiac auscultation. His blood pressure was 180 over 105, his heart rate was 83, and his oxygen saturation was 97%. So they decided to do an EKG on this gentleman. So when you look at this rhythm, what do you see? I would agree with you, you see something bad. Basically, what you have here is a myocardial infarction. And how you could tell is a couple of different ways. First of all, let's look at the QRS complex. QRS, QRS, QRS. Is it narrow? Yes, it is. You have a P wave, P wave, P wave. But what you have here is an elevated ST section. This area right here is an elevated ST section. And typically, this is indicative of myocardial infarction, and this is kind of severe, and you really need to treat this rather quickly. So this rhythm right here is an ST elevation, typically assigned with a myocardial infarction. So what is the treatment for ST elevation? The initial medical treatment during this type of EKG consists of a few different items. Number one, you need to administer oxygen. Oxygen is needed because a lot of times this kind of rhythm, you don't get enough oxygen to vital organs in the body, mostly the brain. The second thing you need to do is to offer some kind of antiplatelet therapy such as aspirin or other type of inhibitors because there's a lot of clotting going on at this particular point. Thirdly, you have to order some kind of anticoagulation therapy such as heparin. This is another very important category. And finally, you need to manage the pain with nitrates or morphine. This is a very severe case, and when you get this, we know all the dangers of heart attack. This is your typical myocardial infarction heart attack that needs to be addressed immediately. And finally, you might have to order some beta blockers going along with this. All of these are the normal management of ST elevation, which can be quite critical. So let's turn our attention to hemodynamics. What is hemodynamics? Hemodynamics is a term used to describe intravascular pressure, oxygenation, and blood flow that occurs within the cardiovascular system. The main goals of hemodynamic monitoring is to maintain adequate tissue perfusion. This way you get oxygen to the tissue. The second reason is that sometimes you could prevent organ failure, especially with cases of shock, cardiogenic, neurogenic, anaphylactic shock, all need some form of hemodynamic monitoring. Sometimes you may have heart disease. That's another reason why you might want to monitor hemodynamics. So there's really good value in understanding hemodynamics, and I know we all had to do it originally when we became respiratory therapists and right out of school. So I'm going to refresh you. Let's talk about some case studies in hemodynamics. This is your first case study. A 48-year-old woman was admitted to our hospital with shortness of breath and extreme fatigue during daily activities. She was previously diagnosed with hypertension, and this was controlled with medication. She had a history of a blunt trauma to her chest in a car accident 13 years ago. There was a heart murmur, a grade 3 heart murmur, in the fourth intercostal space on the left sternal border, which increased with inspiration, as well as a pretibial edema and jugular venous distension during physical examination. An EKG was done, which showed atrial fib with right bundle branch block. She had a flailed tricuspid valve, right ventricular volume overload, and reduced right ventricular function, all determined via hemodynamics. When they did the test with her, her right atrial pressures were in the range of 8 to 10 millimeters of mercury. So my first question to you, are those right atrial pressures normal? Are they high? Are they low? Which one are they? So that's what I want you to first look at this case study and then look at the pressures in her right atrial. So I'm going to refresh you. Here's a little quiz. What is the normal mean pressure range for the right atrium? Is it A, B, C, or D? You tell me. And of course, the answer is A. The normal range for the right atrium is anywhere from 2 to 6 millimeters of mercury. So now we know that, we're going to go a little bit further. Upon further evaluation of the case that we just presented, it was determined that this patient has tricuspid valve regurgitation. Tricuspid valve regurgitation is a condition where the valve between the right ventricle and the right atrium is damaged. So what happens is you get a backflow of blood from the right ventricle up to the right atrium. This is what can cause an increased pressure in the right atrial. This condition could be caused by congenital heart disease, or it also could be caused by chest trauma. Chest trauma is a common cause of this kind of damage. If the condition is mild and there's not much regurgitation, nothing really has to be done. But in some cases, you need to do some kind of surgical intervention. So in her case, they didn't recognize this problem earlier, but this problem got worse over time, and she's going to need some form of surgery on the valve between the right atrium and ventricle, the tricuspid valve in particular. This is our second case study in hemodynamics. A man in his 60s with a long history of chronic obstructive pulmonary disease presents himself as a new patient. He has a medical history of a New York Heart Association Class 1 heart failure with a preserved ejection fraction of 60%. He also has hypertension, hyperlipidemia, and he also has cerebral vascular accident 6 years ago with no residual defects. He has smoked a pack of cigarettes every day from the age of 22 and decided to quit at the age of 60. He also had a stroke. He indicates that he has been well controlled on maintenance inhaler therapy, which included a long-acting beta agonist, a long-acting mucinergic agent, and inhaled corticosteroids. And he said he's never been required to take oxygen at home. His ability to perform daily activities is nevertheless somewhat limited by exertional dyspnea. So he gets a little tired when he exerts himself. So he came into the hospital. They did a right heart catheterization, and he demonstrated a pressure of 35 over 15 millimeters of mercury. So my question to you, they did a right heart catheterization, and his pressures were 35 over 15. Is that normal? Is that high? Is that low? What do you think? You tell me. So another way of putting it is, what is the normal pressure for the right ventricle? What do you normally have pressures for the right ventricle? Is it A? Is it B? Is it C? Or is it D? Which one is it? And the answer, of course, is B. It's normal pressures for the right ventricle is around 25/5. So I wanted to give you a little more background on pulmonary hypertension and its relation to COPD. Typically, if you are a COPDer and you've had COPD for a long period of time, and all of a sudden your condition worsens where you get a little bit exertion on any kind of physical activity, the most common reason for this to occur is what they call pulmonary vascular remodeling. And what that really means is that the airway as well as the vascular system in the lung changes. Remodeling means change. And what happens is the diameter of the vessels decreases, the pressure to put blood through the lung is increased, and a lot of times this can occur as a result of being hypoxic for a long period of time, if you have any kind of inflammatory process in the lung, and finally the loss of capillaries in severe cases of emphysema. All of these conditions increase the pressures in the right lung. As a result of that, the vascular system, you see what they call pulmonary hypertension. And we all know the treatment options for pulmonary hypertension, which this particular case study is not going to go into. I know I'm taking a little bit of detour on what we do in respiratory care, but I thought that it's important for us to understand a little bit about opioid abuse and overdose, especially in regard to the administration of Narcan. Now, in America, you know there's some kind of major problem with opioid overdose. I am sure many of us know people who are addicted to opioids. Now, I'm not talking about your average junkie who's out there shooting heroin. I'm talking about there's some very middle-class people who are on opioids, and it could be a result of some kind of accident and where they were, and then abuse that comes from them. The term opioids includes compounds that are extracted from the poppy seed, as well as semi-synthetic and synthetic compounds, similar properties. Basically, the opioid receptors in the body are receptive to any kind of opioid compound, as well as some semi-synthetic compounds such as fentanyl. Opioids are commonly used for the treatment of pain, and they include some drugs such as morphine, fentanyl, Demerol. There's a whole list of them. The problem is there's a lot of people use these opioids for non-medical use, and as a result of using it for a long period of time, they become addicted. Worldwide, they were saying there's so many overdose of opioids, and a lot of them end up dying. 30% of all the overdoses result in death. So in other words, so many people are overdosing, so many people are dying. So really, Narcan is sort of heaven sent for this particular group. The question is, do we really know what to do with Narcan? If you've seen an opioid addiction, or you've seen someone overdose, but do you know what to do? Do you know it's a little bit different from the pre-hospital setting to the hospital setting? So I hope to cover a case study in opioid abuse and give you a little background with Narcan. So here is our case study on opioid overdose. I want you to meet Casey. She's a 23-year-old female. She was found in a car. Basically, she was unresponsive. She was limp and cyanotic, but her airways appear to be clear of obstruction. She has taken shallow breaths at a rate of 4 breaths per minute, and when they listened to her breath sounds, she had rales in both bases. Her pulse oximetry read 65% on room air, so obviously this is some form of medical emergency. More history on vitals. Her heart rate was 106. Her blood pressure was 92/64. They did some blood test on her where they found her CO2 level to be at 70 millimeters of mercury. Her glucose was 80 milligrams per deciliter. Her temperature was 99.6. Upon physical view, her eyes examined pinpoint pupils, and both her extremities appeared to be covered what looked like needle tracks. She had multiple abscesses and bruises in various stages of healing. Her skin turgor was poor, and she had signs of malnutrition and dehydration. There were 2 transdermal medication patches found on both sides of her right thigh. So she was obviously a drug abuser. Let's talk about opioid toxicity. When you think about opioid toxicity, I'm talking about the fact that some patients or some people, you may recognize certain symptoms. The most common symptoms you may see is what is known as CNS depression, respiratory depression, and the pupils are constricted. These are one of the telltale signs of opioid toxicity. The human body has 3 main opioid receptors, and they are located in the sensory nerves, the mast cells, and the cells of the GI tract. And as a result of these opioid receptors being in these areas, you'll see certain type of effects, which I'm going to get a little bit more into. Stimulation of these receptors typically result in euphoria and a decreased perception of pain and drowsiness. The human body, like I said, has 3 of these main opioid receptors. And when you think about the stimulation of the CNS, think of euphoria, think of decreased perception of pain and drowsiness. Think about that when they're overstimulated, it desensitizes the brainstem to carbon dioxide levels, which results in respiratory depression and basically loss of the airway and any kind of reflex there. When you think about mast cell effects, this commonly causes itching. So a lot of times the people who are on opioid abuse, they sort of scratch because of the stimulation of mast cells. And the GI tract, when you think about the impact of the GI tract, think of constipation. A lot of times patients who are on opioids have constipation, and that's because it impacts the opioid receptors in the GI tract. Typically, you could really overdose. So that's how it basically works in the body. I'm not going into the full details of everything, of all the details with it, but this is a little bit of background on it. So if you found somebody who had an opioid overdose, what would you do? How would you manage them? What signs and symptoms would you see? What kind of intervention would you do? So there's a couple of ways of handling this. Number one, let's talk about acute management. You find someone, they are hardly breathing, and you really need to do something very quickly. So the non-pharmacologic methods to do would be first, number one, maintain the airway, breathing, and circulation. So you got to determine they are adequately breathing, they have a heart rate, and so on. So if for any reason that you feel that their airway is compromised, you really need to consider giving them artificial ventilation. And you could do this with a number of ways. So if their respiratory rate is less than 12, and they are taking these really shallow breaths, you could use what is known as the jaw thrust or chin lift technique. And basically, you would try to ventilate them. Hopefully, you got a big valve mask, and you could do that. Now, I'm saying this if you're in the field. Now, if you're out, if you're in the hospital, obviously, you have the option to intubate them. So the first thing to do with someone with an opioid overdose is maintain their airway and their heart rate. So if you find that their heart has stopped, obviously you're going to give them CPR. But if you find that they're taking very shallow breaths, you really want to ventilate them to give them some good breaths. If they don't respond at all and their mental status doesn't improve from that, then you need to give Narcan. And I got a couple of slides after this to tell you exactly what you need to do. When you think of Narcan as a competitive, short-acting opioid receptor antagonist. Basically, it will reverse the effects of opioids. It is considered a first-line treatment for opioid overdose, and it will either reverse the opioid effects completely or partially. There are many different routes of administration for Narcan. You could give it intravenously, intramuscularly. You could also give it subcutaneously. They actually have intranasal sprays, and you could actually put it down an ET tube. The fastest route is obviously intravenously, followed by IM. And really, it really works rather well. And I have another slide I want to tell you a little bit more about it. This is a chart showing the dosing required with Narcan. If you use IV, IM, or SC, the initial dose is 0.4 to 2 milligrams required every 2 to 3 minutes, up to 10 milligrams. If you are an opioid dependent adult, you may want to give an initial dose of 0.1 to 0.2 milligrams to avoid acute withdrawal, and you repeat this every 2 to 3 minutes, again up to 10 milligrams. I don't want to comment much about children. Even though it's right here, you could read it for yourself, but I just know a lot more about the adult dosing. And remember, you have to differentiate between someone who's a non-opioid dependent versus someone who's opioid dependent, and that could be done by looking if they're if they have IV marks on their arms, or if you have a history, if you know their history as a drug abuser. That is when you would actually look at that. The next topic of discussion is ethical challenges in the ICU. As respiratory therapists and nurses, we have experienced death at the bedside many times. Throughout my career, I couldn't even tell you how many patients I've seen pass. And, well, the real conversation is here. How about the patient where you have different choices made by family members on the patient? Sometimes these choices go against what the patient wanted. So there are a lot of ethical challenges going on with the patient who are critically ill, who are basically dying, who are basically hospice patients or need palliative care. So I want to get a little bit into a story about this. I want to tell you a little bit of a case study, and I want you to challenge you with some of the choices that got to be made at the end of life. My case study is about a 77-year-old man whose past medical history included hypertension, high cholesterol, and also previous alcohol abuse. He has mild cognitive impairment. He was brought to the ICU because he had a perforated sigmoid colon, and as a result of that, ended up going into septic shock. Complications during his ICU stay included ARDS, mild disseminated intravascular coagulation, and acute hepatic necrosis. After being transferred to the surgical floor, he had an unwitnessed fall from his bed and had a cranial CAT scan showed that he had an acute subdural hematoma with an underlying hemorrhagic contusion on the left side of his head and a 5-millimeter displacement of the midline and intracranial structures. So, not a happy story for this gentleman. As a result of the fall, he was taken to the operating room and underwent a craniotomy for the evacuation of a subdural hematoma. 12 days after the procedure, he was not on any kind of sedative medications. He was still in a coma, and his best motor response was an abnormal flexion on the left side. He was on mechanical ventilation, and the consensus opinion of the clinicians who were treating him was that he was not likely to make a functional recovery. So here was a gentleman on a ventilator in a coma, has a subdural hematoma, and he looked like he wasn't coming off the vent anytime soon, and there was consensus that the clinicians who took care of him felt that he was not going to make any kind of likely functional recovery. So you know the case study, and I want you to tell me which is the best options for this patient. Number one, meet with the family and tell them there is no hope of recovery and you will be discontinuing mechanical ventilation. Or, number two, meet with the family with the goal of ascertaining the patient's wishes regarding the continuation of active medical treatment. Number three, placement of the patient in a nursing home with a high level of care. Number four, meet with the family and ask them whether they would like the patient to have a tracheostomy. Or number five, send the case to the hospital ethics committee and ask them what they think. So which one of these is the best option? And I'd like you to answer that in your Q&A. Just tell me what your options are. Every hospital has a sedation scale they use. At our hospital, my past hospital, we use what is known as the Richmond Agitation Sedation Scale, or called the RASS score. And the purpose of the RASS score was to determine the level of sedation, and you would do this each day. So the point of this, if you have a RASS score of a -5, do you think you can wean the patient? Absolutely not. So the RASS score is a very good tool, especially for respiratory therapists. When you're weaning a patient, you really want someone to be between the levels of 0 or +1 or -1. If you're 0, you're alert and calm. If you're a +1, you know, you're a little bit restless, but you're not really aggressive. And not -1, you're a little bit drowsy, you're not fully alert, but you can open your eyes when someone says, hey, open your eyes, and you open your eyes. So if you're going to wean somebody, you want to wean someone from the -1 to a +1 in regard to the RASS score. Your best score is 0. So I'm going to tell you some scenarios. You could take a look at this chart. You could see when you're a +4, you're combative, you're violent, you're immediately danger to the staff. And when you're -5, you are like unarousable. So that means you got so much sedation on board, you're not even responding. So just sort of remember these scores: -5 to a +4. +4 is combative. -5 is you're zonked out. So I'm going to ask you some questions. I have 4 questions for you on the RASS score. Number 1, what is the score if the patient is the best score that you could wean a patient from mechanical ventilation? So what RASS score is the best when you want to wean someone from mechanical ventilation? And you know the range. It's from -5 to a +4. So what's the best score? Number 2, what is the score when the patient is alert and calm? So what score is it when the patient is alert and calm? Again, type it in the Q&A. Number 3, what is the score when the patient is in deep sedation, no response to voice, but movement or eye opening to physical stimulation? So they do respond to physical stimulation, but they don't respond to voice. What kind of score would that be? And finally, what is the score of a patient frequent non-purposeful movement and fights the ventilator? They're bucking the ventilator, they have frequent non-purposeful movement. What kind of score would that be? So again, put all of these in the Q&A, 1 to 4, and let me know what you think. Thank you so much for joining my presentation. Again, this is my reference page. If you have if you want to dig a little bit deeper into any of the topics I discussed during this webinar, here they are. There's some great sources for you, and I want to thank you so much again for joining me.